Dementia is a neurodegenerative disease that affects around 55 million people worldwide. You may be aware of the common forms of dementia, like Alzheimer's disease, dementia with Lewy bodies, vascular dementia, and frontotemporal dementia. Frontotemporal dementia is the most common early presenting dementia, and this 2018 study published that the most common ages of onset are between 45 and 65 years. Men and women are affected equally, and between 20 to 50% of cases are hereditary. As the name suggests, frontotemporal dementia is caused by atrophy in the frontal and temporal lobes. Unlike other dementias, it spares the occipital and parietal lobes. The atrophy is a result of a build-up of abnormal proteins like tau and ubiquitin, which prevent the cells in these lobes from functioning properly. There are lots of different subtypes of frontotemporal dementia, depending on what protein causes the disease. The frontal lobe is responsible for functions like personality, social skills, emotions, and language, and the temporal lobe is for understanding, memory, and speech. Frontotemporal dementia disturbs these functions, resulting in its distinctive symptoms like apathy, which is a lack of emotion, disinhibition, like making lewd remarks in public, memory impairment, apraxia, which is the loss of the ability to carry out skilled movements, and irritability. But what does this look like in practice? Well, let's meet our patient, Julia. She is a 56-year-old lady who has a 2-year history of changing personality and apraxia. Her husband has described that she is struggling more and more with things like brushing her hair and making food. He also notes that she is becoming more argumentative with her friends. She swears in public and is becoming more and more confused. Diagnosing any dementia is challenging, and it's previously been estimated that around 40% of frontotemporal dementias are misdiagnosed. Additionally, a 2017 study published that they are also underdiagnosed due to difficulties in recognising the disease and differentiating it from other psychiatric disorders. The first step in diagnosis is to take a comprehensive history. As we saw with Julia's husband, family members and carers are important sources of information when gathering a dementia history. According to the PMJ, if a clinician suspects frontotemporal dementia in someone under 70, they should refer them for assessment, which could include common exams like the MMSE or MOCA. A 2016 study published that the MOCA was more effective in measuring cognitive impairment in frontotemporal dementia patient than the MMSE, with the MOCA showing a successful detection rate of 87.2% compared to 73.3%. Other useful examinations include the Frontal Assessment Battery, Executive Interview, and Frontotemporal Dementia Rating Scale. After an assessment, Julia may have some tests. This could include FBC to rule out anemia, CRP for inflammatory conditions and thyroid function tests, as well as general OBS. An area of increasing interest when investigating dementias is cerebral spinal fluid markers. Research has shown that markers like serum neurofilament light chains are strongly elevated in frontotemporal dementia, and others like neurofilament medium polypeptide, aquaporin 4, and neuronal pentraxin 2 are useful in differentiating between affected and unaffected patients. For screening, a brain MRI is usually mandatory if frontotemporal dementia is suspected, as you can easily visualise atrophy in the frontal and temporal lobes. CT scans can also be done if MRI isn't available or is contraindicated. PET scans measure fluorodeoxyglucose uptake, which indicates levels of glucose and thus metabolism, or lack thereof, in the brain. You may remember learning earlier that between 20 to 50% of cases of frontotemporal dementia are hereditary. Genetic testing has become a highly researched area, and as well as family history being an indicator for disease, detecting mutations in genes like microtubule-associated protein tau, granulin, and repeats on chromosome 9 can distinguish frontotemporal dementia from other diseases. Research is going on all over the world to investigate the effect of these mutations and create early screening tools to detect them. So after Julie is investigated, she gets a diagnosis of frontotemporal dementia. There are some criteria that healthcare professionals may use to help diagnose her, like the McCann or Neary criteria and international consensus criteria for behavioural variant frontotemporal dementia. The management options of frontotemporal dementia is a highly under-researched field consisting of mixtures of pharmacological and non-pharmacological options. A 2017 meta-analysis stated that there is a lack of quality studies and reports for managing behavioural symptoms in frontotemporal dementia. The study also stated that there are currently no US FDA-approved treatments for frontotemporal dementia, further highlighting the lack of research. Another 2017 review concluded that non-pharmacological options showed more evidence in reducing symptoms of dementia. So what's better, pharmacology or no pharmacology? Well, let's look at this paper. Published in 2021, researchers searched through PubMed to find evidence on pharmacotherapy in frontotemporal dementia. Firstly, when discussing any treatment for dementia, it's important to recognise that it is always individualised depending on the symptoms of the patient. The paper first looked at selective serotonin reuptake inhibitors, which the BMJ does recommend to treat symptoms interfering with daily life. This 3-month study looked at the use of fluoxetine, sertraline and paroxetine and showed they were effective in improving symptoms like depression and disinhibition in at least half of the subjects. However, sample size was only 11 and 2 patients withdrew due to side effects. This 2002 study looked at the effects of various psychotropic medications in patients with frontotemporal dementia. The SSRI paroxetine was effective in reducing anxiety and repetitive behaviours in 8 out of 11 participants. However, it's extremely important to consider all side effects when prescribing medications, especially to treat psychiatric illnesses. 2 patients who took paroxetine experienced adverse side effects like stomach upset, anxiety and depression, and decreased speech output. Another drug looked at in this trial was trazodone, a serotonin receptor antagonist and reuptake inhibitor. It shares many properties with SSRIs. However, its strongest property is its antagonistic action against the serotonin 5-hydroxytryptamine receptor 2A. This randomised control trial showed it significantly reduced neuropsychiatric scores in 51% of patients and provided a significant benefit in improving behaviour in patients with severe eating disorders. However, this trial also had a small sample size of only 26 patients. Cholinesterase inhibitors are well known in the world of Alzheimer's, yet their use in frontotemporal dementia is less common. In this open-label study, rivastigmine showed a statistically significant reduction in points in the neuropsychiatric interview. Alternatively, it did not show any significant reduction in the MMSE score, bringing into question its efficacy in improving cognitive function. Another parameter measured was the relative stress scale, which measures caregiver burden. According to this trial, rivastigmine provided a significant reduction. It may seem impossible to produce a drug that improves a patient's symptoms while also having an impact on the family and friends around them, but by measuring outcomes like the relative stress scale, it's now a parameter that can be considered. Non-pharmacological therapies are still first line when treating frontotemporal dementias. Things like educating friends and family, modifying the home environment, and improving communication can help alleviate symptoms. This 2019 study looked at strategies for caregivers to make, including using short sentences, making eye contact, and remaining calm. Another study in 2017 concluded that speech therapy may benefit patients with symptoms like dysarthria, apraxia, and hyperphonia. So once Julia receives her diagnosis, she gets information from her GP regarding her condition and how to manage it. A care plan is made, and her home is checked over to see if there are ways it can be made more comfortable. Should Julia's symptoms severely decline and affect her quality of life, her doctor may consider prescribing some medication. There are many emerging therapies occupying the dementia research field, and although the number of studies for frontotemporal dementia is small, it's ever growing. Phase 3 trials are underway investigating tau aggregation inhibitors, which reduce protein buildup in the brain. We mentioned earlier that granulin is one of the major genes associated with frontotemporal dementia, and in 2014 there was a pilot study investigating amiodarone and its effect on increasing progranulin in patients. Although the study showed no significant results and had a sample size of just 5, genetic therapy is only just emerging and could be a great direction for frontotemporal therapy. Prognosis in frontotemporal dementia can vary from 6 to 13 years, depending on the type and symptoms. This 2011 study reported that behavioural variant frontotemporal dementia has a lower survival rate than other types like semantic dementia. However, there was a location bias in this study and survival generally varies. This 2005 multi-centre study published that frontotemporal dementia survival rates are significantly shorter compared to Alzheimer's disease. There are some questions we can consider, like is this due to lack of research in the field, or potentially the severity of the disease, or ineffective treatments? Nevertheless, it is clear there is still a long way to go in reaching the goal of pharmacological treatment for frontotemporal dementia. Non-drug therapies still lead the way, and it's crucial for clinicians to take a holistic approach when treating this disease. Helping the patient and family understand the disease, preparing for the future, and providing ongoing support for both patients and their carers are the most important treatments for frontotemporal dementia.